Hi, everyone. Thank you for joining us. This is a fireside chat proving opioid reduction using cannabis. I'm really excited about this because I think it's really important that we incorporate in our conversations about cannabis and drug usage as much scientific data really on any topic that we can, because we are so, I don't want to say lacking in scientific data, and you guys can join in because I know there's a lot internationally available, but that's not always usable for us. So that said, I want to welcome you guys to this conversation. I'm going to let you introduce yourself. AJ, you've been involved in the Ohio program since it started, and we're talking since it started tracking opioids, cannabis, and the reduction of opioid use. Why don't you tell us a little bit about yourself and how you got interested in being a cannabis pharmacist and how you got involved in all this. And then Joe, I'm going to let you jump in and tell us a little bit about your background and then how you got involved in this. So AJ, you go first.
Hi, yeah, absolutely. Thanks for having us, Vivian. It's great to be here and be included. So as you said, I've been in the program since the beginning, and I know Joe has too. And Joe and I actually met I think the same way that we got involved in cannabis, and that's just through being active pharmacists. We were both involved in our state pharmacist association, and that's actually where I met Joe. Was we were down in Columbus, the state house in Ohio, and we were talking with our legislators about pharmacy benefit manager reform, or PBM reform, pharmacist reimbursement. I know I was also involved in doing a little work with the legislature on getting medication synchronization programs allowed through the state, again working with PBMs to allow for reimbursements for those types of programs. So through traditional, lobbying on traditional pharmacy efforts, when Ohio decided it was going to pursue a medical marijuana program, I got a call from one of the gentlemen involved with the Ohio Pharmacist Association, who we worked with on all these other PBM issues, and he said, "Hey, what are your thoughts on medical marijuana?" And I said, "Well, in this state, I don't think so." And he goes, "No, there's going to be a bill that the legislature is going to be looking at, and they're going to put dispensaries under the oversight of the State Board of Pharmacy, and we want to know what they think about becoming involved in the program. If they'd go to bat and think there'd be enough pharmacists to require pharmacists be involved at in each individual dispensary." I was like, let me do a little bit of research and I'll get back to you. So looked around and did research on were pharmacists required in any other programs in the state, in the United States, and the answer was yes. There's required to have some degree of medical oversight in New York State. Connecticut was actually required to be run by pharmacists. Minnesota has pharmacist involvement. So I was like, well, if there's other pharmacists doing it, let me reach out to folks who speak the same language. Was lucky enough to get in contact with a pharmacist who ran a dispensary in Connecticut. I went and shadowed for a weekend there just to see what she actually did on a day-to-day basis. And it was a little weird walking in there and smelling a dispensary for the first time. But what was really cool was I got to witness this pharmacist sitting down and talk with patient after patient about dosage forms, about how different dosage forms had different durations of action, different onsets of action. I was like, man, I think she uses more pharmacy skills here than I do at a traditional retail pharmacy. Mm-hmm. So kept doing more and more research and found out that there was, as you said, Viv, there's a lot of evidence from overseas. We're just not taught about it in medical, in medical or pharmacy schools over here. So I was like, you know what? I think I'm not only interested in this, but I might be interested in applying for a dispensary license. So I did, was not successful in obtaining one, but, pharmacy is a small world. And there was a pharmacist who I had worked with at Rite Aid, who had been lucky enough to have won a dispensary license. So I called him up and was like, hey, if you need somebody to run the place, be more than interested in learning, more about the industry. And they needed somebody to run the place, and I have not looked back since. Now I am no longer with that dispensary. I am now the retail director for Buckeye Relief. So I've just got done opening up the second dispensary from the ground up. So been through 2 inspection processes, and it's definitely a different animal than dealing with traditional pharmacy, but the same still holds true now than as what I saw in Connecticut. And that's, I feel I use more pharmacist skills, all those skills that, pharmacists are really the experts, absorption, distribution, metabolism, excretion. I think I use more of that knowledge now because it's such a novel drug and we're on the cutting edge. You need to have those basic skills to be able to evaluate the literature as it comes out. So it's a really exciting place to be. Not looking back. Don't see myself anywhere else. Now, Joe, let you speak a little bit to your journey and how we got here.
Well, as you can imagine, AJ and I have had very similar journeys to get here. I did kind of the same thing after practicing in various situations in pharmacy, retail. I did 15 years of hospital pharmacy, and I even had a compounding pharmacy. And I've always been intrigued by this. And when the legislation passed in Ohio, I made a beeline to find out, okay, are pharmacists going to be involved or not? And it turned out they ultimately pulled that requirement, but the Board of Pharmacy was going to still run it. The CEO of our company now really wanted a pharmacist to be involved, and she has to this day, and I'm thrilled about it because it's exactly like AJ says. You utilize the knowledge that rather than the doctor prescribing a specific drug in a specific dosage and a specific frequency, the doctor just says, I want you to have this drug class. And it's up to us to figure out what's the most appropriate therapy, like he was talking about, with duration of action, onset of action, route of administration. It's just been wonderful to do it this way.
Wonderful. This is a little bit of a sidebar, but it's a question that's been rolling around in my head regarding pharmacists and, like you said, managing cannabis and things like that. Now, obviously, there are a lot of states now that are legalizing cannabis, and they're not necessarily medical marijuana. Is there an opportunity to pharmacists to work with a regular dispensary? Is that what you guys have been doing in the offering your pharmacy? Or, and forgive me if I'm getting this wrong. I'm not sure if you guys are strictly a medical marijuana state or they've legalized marijuana. But one of the things I'm thinking is, can pharmacists become involved with a place that has a marijuana dispensary, and then offer basically what you said, like, or I don't know if it's called MTM, but for people who want to take it for medical reasons and have just more input and more guidance than, the 22-year-old behind the counter.
Yeah, I'll go first, AJ. Absolutely, there are opportunities everywhere, as you know, and it's not a bad question to know whether Ohio is a medical state or not. Every state seems like they're so different, but Ohio is a strictly medical state that doesn't require a healthcare professional be at the dispensary. But I'm telling you right now, at least 20% of the time, it's necessary for people to have a healthcare professional there to guide them through. So there are a lot of opportunities, but it just doesn't come to your doorstep. You have to go looking for it.
Got it. All right.
Yeah, and I would add on that, while Ohio is a med-only state, I believe there is a place for pharmacists even in an adult use market, and reason being, with medical marijuana states, there is still a barrier to entry. It's not covered by insurance, and part of that barrier is obtaining a medical marijuana card. So up front, patient has to pay for a doctor visit and then pay the state of Ohio for their card before they go and purchase medical cannabis. So some patients can't afford that upfront barrier to entry to even enter into the medical market. When you remove that barrier, while prices might be higher in an adult use market, patients don't have to pay that initial barrier for entry, so they might be more willing to go in and try it. So so even when states go adult use, there could be a huge increase in patients who might have those medical questions but are just presenting to the dispensary for a first time.
Right. Okay. Thank you for that. How did you figure out that the Prescription Drug Monitoring Program, otherwise known as PDMP, the data in Ohio might be helpful in understanding the effect on opioid use in your state? Pain management programs, doctor has to stop prescribing opioids, etc. I don't know who wants to jump in first.
Go ahead, AJ.
We kind of fell into it. Joe and I were just talking one day. I think, and Joe said, it'd be great if we can somehow figure this out. Is there some way that we can prove it? And, while we're on the phone, I think Joe had mentioned, I think it should all be in Oars, and it all gets reported to the same place. And like, well, yeah, it would all be there. We're like, well, how can we pull it out of there? And then, we just kept the conversation going and kept asking those kind of questions until we found a roadmap to kind of pull that data out of Oars and try and do something useful with it. Joe?
Yeah, there's multiple states that I think add cannabis to their prescription drug management programs. New York comes to mind, Connecticut, like AJ mentioned, and there's not a lot of people that realize that when you go into the pharmacy or your doctor, they can see not only the narcotic prescription drugs that you use, but also your cannabis use now. It's all together. And kind of seeing both of those products together on the same screen made us realize, whoa, we're probably seeing a big decrease in opioid usage with patients who use cannabis. So that's kind of what prompted us to go down this road.
Ohio is one of the few states that is using the PDMP system to monitor marijuana purchases. Are you aware of other states that are doing that? You mentioned Connecticut, but are there any other ones?
Yeah.
Joe, do you want to speak to that?
Yeah, I think Illinois does, Arizona does, Minnesota. I think the states that mainly have medical programs now are the ones that are. New York is one of them.
North Dakota, Virginia.
Yeah, right.
Are these all states that are strictly med marijuana?
Mm-hmm. Yeah.
So
Illinois has adult use, but their medical program appears to still be going through the PDMP.
Okay. So what would happen if these states, are these on the ballots to just legalize marijuana? Would that take away all these opportunities to drill down and do this kind of research?
It's a great question, and more than likely you'll see some change in that where the purchases aren't monitored by a big database. Although I've heard states like Colorado who've been adult use for a long time are looking for a way to make sure those purchases are put into the system so that patients don't go from dispensary to dispensary to purchase their products. So I guess there still could be a potential to use these.
Okay. How do healthcare professionals access the cannabis purchasing information, and what do they do with it?
AJ, you go ahead. You're a more recent pharmacist on the bench than I was.
Yeah, it's kind of interesting. I get a lot of phone calls from folks I graduated with, other docs that I worked with in traditional pharmacy that just say, what is this that's showing up on the report? So as Joe had alluded to earlier, what makes Ohio unique is when we report these medications to the Prescription Drug Monitoring Program in Ohio. Our program is called Oars, the Ohio Automated RX Reporting System. When a patient goes to a pharmacy and gets an opioid prescription prescribed, that pharmacy reports it to Oars. It shows up on the patient's Oars report. If a patient goes to a dispensary, that dispensary also is submitting it to this Oars database. So next time patient goes to get a controlled substance filled at a pharmacy, or they go to their prescriber's office and that prescriber pulls their med history report, their Oars report, they're going to see that cannabis had been dispensed, and they'll also be able to see where their opioid prescription has been dispensed. So anytime that report is pulled by any healthcare professional, they'll be able to see cannabis use on there. Now, as far as how prescribers are using it, it's kind of a novel treatment here in the state, not novel, worldwide or with the human species in general, but in the state of Ohio, it's kind of a new novel approach. So most of the questions that I field are just, is that what I'm seeing? Is that what this weird line is on their Oars report? Is that a medical cannabis product? So I think most docs just use it to see, is my patient on medical cannabis? Beyond that, there's very few prescribers who would know what to do with that information. Joel, let you chime in on that.
Yeah, so I think your last question, AJ, was how do doctors utilize the data?
Yeah, Joe, what do you hear from docs other than, is that what this is?
Well, it's interesting. We're seeing a transition in the way the program works in Ohio. We're 4 years into it now, and I can remember multiple patients coming in saying, my doctor saw there's cannabis on my profile, and now he's kicking me out of my pain management program.
Hmm.
Two, I think advancing now to trying to understand what each one of those words mean in terms of THC content and route of administration. So, and that what prompts sometimes these calls that AJ is talking about from physicians. I just want to know how much THC this patient is taking over the course of a month, per se, to kind of get a sense of how they're handling their therapy. So I think you're starting to see. I wish it was. I wish it was. People liked it more, I think, but because I think it could be good nationally, but I don't know if it'll get there or not. I mean, it was a bold move by Ohio to do it this way.
So why do you say people like it more? What is the pushback? Are you seeing the pushback from the other states who don't want to do it? Are you seeing pushback from the medical or the marijuana community? Who doesn't like it?
I think just the monitoring, it's barriers to entry for patients and maybe physicians. It makes it a lot of people that have used cannabis for a long time just don't want one more roadblock. They just want to be able to come in, get their cannabis, and not have to worry about, okay, this, you can only have so much in Ohio over a period of 45 days. And that's monitored pretty strictly from dispensary to dispensary. Everybody knows. And that, I think, is what some of the pushback is.
Okay.
Yeah, and I think something worth noting is at the dispensary level, because healthcare professionals are not required to be on site, when dispensaries pull up a patient's Oars profile, the only thing that displays are cannabis purchases. So if a patient goes to a physician's office or to their regular pharmacy, they get the entire Oars profile. So they'll be able to see all controlled substances prescribed, versus if a patient comes to the dispensary only sees cannabis purchases. So we only get half of a report, so to speak. The other side of that, though, is it's not just a prescription drug monitoring program on the dispensary side. That Oars system is also what serves to monitor the patient's recommendations. So that's how the doc signs a patient up for a card. That is how we at the dispensary verify that the patient's recommendation is active. And it's also how, as Joe was alluding to, that's also how the state tracks cannabis purchases. So patients can only purchase a certain amount of cannabis over a 45-day period. So every time a patient comes to the dispensary, we have to check that registry and verify that the purchase the patient's making is not going to put them over that allotment.
Let me just get this straight. So when you go to a pharmacy and you pick up your opioids, the pharmacist can see your full history, right? Medication history. Correct. But when you're in a dispensary, you're only seeing the medical marijuana, right?
That's true.
That's correct.
True.
So I'm wondering, what is the justification by that? Because if they're treating it as a drug, wouldn't they, and they want a medical professional there to monitor what is going on, wouldn't it be helpful for you to also know the full medical history and what they're taking, so you can better gauge and monitor what their what their goals are, or better enable what the goal of taking?
I mean, it's such a great point, Vivian, and it's very observant of you, because in some dispensaries we have these healthcare professionals who are wanting to look at the whole profile of a patient and what all the medications they're taking and how frequently they're taking them. But it's almost like we've just dipped our toe in the water of trying to make this a medicine, and not we haven't dived in.
Or fully accept it, because I know one of the big things that you want to be able to monitor interactions, success, dosing, all that kind of stuff. But if you're not knowing everything else that everybody's taking, right? How can you do that?
Right, exactly. And the way the program was set up, there really isn't a requirement for healthcare professionals. So they obviously felt there wasn't a need for those bud tenders, or whatever you want to call them, at the dispensaries, to see that information on a patient.
Got it. Do marijuana purchases affect morphine equivalent doses for patients on opioids?
Well, the thing is, this MED or morphine equivalent dose is based on a baseline of basically codeine, some equivalency to codeine. So, like hydrocodone is a 0, and fentanyl is like a 10 or something. So each milligram dose of these products are provided an equivalency, and I think. What's interesting to note, to answer your question, no, cannabis doesn't affect that in a negative way. It doesn't increase your MED, which is kind of a red flag for pharmacists and physicians to look at if they're prescribing opiates to patients. And there's a noticeable actually decrease in that MED because the patients are not taking their opiates anymore, and now they're using cannabis instead.
Well, it's kind of the whole point of this panel, right? Is to prove that if they are on using the marijuana, then they can decrease their other stuff.
Well, and it goes back to the question that you asked AJ. How did you even think to use this data? And that when you're working as a pharmacist at a regular pharmacy, you see that MED all the time, and it's almost like a chart of the effects or how the patient's what's the patient's MED has been over time. And boy, there's just such a noticeable drop in it. And then you also see cannabis on their profile. You kind of put 2 and 2 together. I would like AJ to kind of chime in though, because kind of understands this whole concept better.
No, so on the Oars report, as Joe had said, there is actually a field in the upper right-hand corner. If you go and you're looking at from a physician's office version of the Oars report or from a regular pharmacist version of the Oars report, and there is the patient's MED field. And the higher that patient's morphine equivalent dose is, the higher, the higher dose of opioids they're on. And the thing that pharmacists are always worried about and physicians are worried about is the higher that MED total is, the more risk there is for, an accidental overdose with an opiate. So really the thing that we are monitoring for when we're looking at MEDs is what's the patient's risk for, respiratory suppression. Lower MED doses mean patient is on a lower dose of opiate, so they should have a lower risk of that accidental overdose. Because cannabis actually does not affect any receptors on the brainstem, cannabis does not decrease the respiratory drive in patients. So in patients who are on high doses of opiates, when those opioids bind to those receptors in the brainstem, that's what causes respiratory depression. Because cannabis does not have there are no CB1 receptors in your brainstem, we don't have to worry about respiratory depression in those patients. So while cannabis, like Joe said, does not have a direct influence on the morphine equivalent dose, just because a patient is prescribed cannabis does not make their MED number go up or down on their Oars report. What we had heard anecdotally from patients is, hey, since I've started cannabis, I'm using less of my opioids. So in theory, that should mean in those patients, we should see that MED going down on those patients' reports.
Okay, great. So Joe, you kind of touched a little bit about this earlier or a moment ago, which is marijuana being considered a red flag. Why don't you explain what the red flags are and then tell us what you think? Is it considered a red flag?
So, most healthcare professionals and certainly pharmacists learn through continuing education and the DEA and some of the state pharmacy boards to monitor for red flags. And some typical red flags on patients are going to multiple physicians, going to multiple pharmacies, refilling their opiate prescriptions early. Those are sources of red flags. And it is certainly cannabis does not contribute to that red flag rule. I do hope that pharmacists that aren't involved in the industry wouldn't consider it one. Part of the problem with cannabis and historically has been that if a patient goes to a physician or particularly a pain management clinic, if they check the box for cannabis use, that's kind of their own red flag there that they may have a higher addiction potential, and which is just untrue. And I hope we can get that message out to the pharmacists and healthcare professionals out there that cannabis use should not be considered a red flag. It's actually should be beneficial to the patient.
But didn't you say earlier, and I don't mean to interrupt you, AJ, but didn't you say earlier that some of the clinics that you see that are working on drug addiction, if they see that somebody's taking marijuana, they'll kick them out?
That happened probably early on in the program a good bit, because you get the impression that the intake form asks for cannabis use, and then their patients are usually urine drug screened to either check to see that they're taking the opiates that they're being prescribed, and to see if they don't test positive for THC for just that same reason. Our hope is that that is changing. We see it changing.
Okay. So that's the old school. AJ, did you want to chime in?
Yeah, I think unfortunately it's just it's part of the cannabis stigma. When I hear red flags, there are certain things pharmacists should be looking for. You want to check out how many different prescribers is a patient going for and getting controlled substance prescriptions from. You also want to look at how many different pharmacies the patient is using. How many different types of controlled medications the patient is on. If they're on a combination of opioids with a benzodiazepine, that puts them at further increased risk for sedation and respiratory depression. So when we start looking at different prescribers prescribing medications, patient going to different pharmacies and pharmacy shopping, multiple different types of controlled substance medications in traditional pharmacy, that's when Oars would so-called raise the red flag and say, hey, you might want to evaluate this prescription, make sure that there's that the patient's using it appropriately, there's not an increased risk for any type of abuse. But as Joe said, now we got cannabis added to the mix, and there are going to be some physicians who just look at that and say, well, that's a big red flag. But we've also, I think we've seen the opposite be true, as Joe had said. When patients start cannabis, a lot of them are backing off that opioid dose.
Great. The Ohio Medical Marijuana Program is run by the Board of Pharmacy. What challenges does this create for Ohio dispensaries? How has it helped? I should say, and how has it helped?
Well, we have the luxury as pharmacists to understand kind of how the Board of Pharmacy thinks and what they need. And I think it was a big step for dispensary operations that didn't have a healthcare professional involved to understand how important it is to follow and obey all the rules for not just dispensing and making sure labels are correct, and but also to make sure the products you're receiving are correct. Inventory, control is so important. Most pharmacists now are just so used to doing Schedule 2 inventory, and that's quite frankly, this is a Schedule 1, so they look at it the same way. So it presents some challenges into sort of just having that foundational understanding of how important it is to treat this as a medication in the eyes of the Board of Pharmacy, and not being flippant about it. But I'm sure most dispensaries out there aren't really into all the rules and regulations that are required, but we kind of, I guess in a way, we appreciate it, right, AJ?
Yeah, I mean, I certainly think that, having the Board of Pharmacy involved, it's certainly put me in a comfortable starting place, because as Joe said, we were familiar with how traditional pharmacy operates, and a lot of the dispensary rules that Board of Pharmacy crafted sort of mirrored those traditional pharmacy rules in terms of inventory and dispensing. I know we have a lot of systems of double checks in place, and just how we fill an order in our dispensary that mirror traditional pharmacy. So that background knowledge and training in that area has certainly helped. And then I also think, from the Oars aspect, having Board of Pharmacy involved, while it was new for the industry in the beginning, having to deal with this prescription drug monitoring system, as an operator now who only sees the registry side, so that side that does not have all of the patient's narcotics or benzodiazepines listed, it's nice to have that system built on a platform, and we have the patient's registration card. We have all the patient's recommending physician information. We have the patient's purchase history all in one location. So while it was a big learning curve initially on the industry, I think it's really helped us out in the long run, and it's given us the opportunity to do something with that data. That had we used had they went another route, this perhaps would have been a lot heavier of a lift.
Mm-hmm. Okay. Do different types of cannabis, such as flower or tinctures or edibles, appear differently on the Oars report? And how can you tell if a patient is getting an appropriate dose?
Joe, you want to walk us through how it looks on the Oars?
Yeah, so on the Oars, you can see the actual name of the product first, and then it gives THC content, and then CBD content, and then the size of the product. I don't think most pharmacists in Ohio realize what all those numbers mean on there, but you can basically. In the processed goods, we kind of look at the milligrams of THC and see how many total milligrams they've purchased in those.
Mm-hmm. And so it does vary, since it is the same report. That they can pull on the cannabis side as they pull on the Oars side. All the same fields are required. So there is the name, there's the dose, and just like regular opioid prescriptions, pharmacies have to report the day's supply. How many days is that prescription of the opioid supposed to last that patient? We still have that day's supply column for cannabis as well. So what the Board of Pharmacy actually does is it evaluates products based off THC content. So with flower, we actually report the weight of the flower that is dispensed. So in Ohio, cannabis is dispensed in increments of 2.83 grams, so 1/10 of an ounce. That makes Ohio a little bit unique. In most other states, the unit of sale for cannabis is 1/8 of an ounce, or they sell it by the gram. In Ohio, we have set increments that companies must package and dispense their cannabis. So it's in increments of 2.83 grams. So each 2.83 gram unit of flower is 1 day supply for a patient. And a patient can purchase up to 45 days supply in a 45-day period. For processed products, it goes by the number of milligrams THC that's in the product. So for vaporizer cartridges or for edible products, they look at the milligrams of THC that's in the packaged bottle, and then based on that, they assign it a day supply. So for edibles, every 110 milligram increment of THC is a 1 day supply. Mm-hmm. So if you have a bottle of 100 milligram bottle of gummies that has 10 milligram gummies in it, that counts as a 1 day supply for the patient.
Beverages?
So averages?
Beverages. Isn't that a whole is that a different sort of ball game?
So beverages still fall under the edible category.
Okay.
Something that's unique though is that it's up to like in edible products or in vaporized products. So for edibles, it's 110 milligrams as the day unit. If a company wants to make a trial size for a patient, so maybe a package that has only 1 or 2 gummies, they are allowed to do that. So say a company makes a gummy packet that has 2 10 milligram gummies in it. Even though it's only 20 milligrams in that package, it counts as a full 1 day supply. And those don't stack for patients. So if a patient, would like to purchase a couple trial size packs, even though it's less than 100 milligram total, they get hit for that full day supply. And if they purchase multiple of those trial size packages, it's 1 day supply plus another 1 day supply. So for those patients who want to try different products with those processed products, sometimes that can ding them, so to speak. So, they're using their days quicker. and using that allotment a little bit quicker. So it can get kind of complicated for patients and dispensaries. And that's one of the things they're looking at when they're pulling that Oars report is not only what the patient has purchased, but how much they've purchased and how much they have left. So not only are patients budgeting, their money because cannabis is not covered by their insurances. Now they also have to worry about how many days supply do I have left, and if I purchase a smaller package of edibles, if it's below a full 1 day supply, is that going to run me short on my days, or will I have enough days left to purchase medication?
That seems unfortunate when you're trying to figure out products that work best for you. Not having real access to the trial sizes.
That is a challenge in the program.
Yeah. I have this question, but it seems like we already answered it. Are questions restricted to a certain amount of cannabis in Ohio? We've been talking about that the whole time, right?
Yeah, that's right. There is a specific amount that patients are allowed to have over a course of 45 days.
Mm-hmm. Right. So how can we use the Oars data to figure out how cannabis is affecting other prescribing in Ohio? I didn't read this one through. Prescribing what? Prescribing drugs? How can we use this Oars data to figure out how cannabis is affecting other prescriptions in Ohio? Is that the question? Or is it other prescribing entities? I want to say that question again, by the way. Is it prescriptions instead of prescribing? So how can we use this Oars data to figure out how cannabis is affecting other prescriptions in Ohio?
Yeah, and that's basically this whole conversation comes full circle. That's when we started looking at these dispensations on the Oars report from a pharmacist perspective, meaning all the medications a patient takes and cannabis, and realizing that how can we utilize this data, and that's really what prompted us to contact the Board of Pharmacy and the people that run the Oars program. Is there any way to extract this data? And we had to hire or bring on a researcher at one of the universities in Ohio to help us do that.
Yeah, so we're very fortunate to be working with Dr. Christine Bengler-Krish at Neomed. I have the pleasure as a Neomed alum to serve with Dr. Krish on a couple of different committees up at the university, and also had helped her develop a medical cannabis elective course at Neomed. And just through conversations, when Joe and I were kicking around, well, how do we get access to this data? It looks like we can potentially request or petition the board to have access to de-identified data. So data that does not have any patient names associated with it. We needed help looking through the IRB process, which Dr. Krish was extremely helpful in helping guide us through that process. And once we submitted that to the state and we got this big data set, it was opening it up and figuring, okay, now what? Now we have all these different fields. So every field that was reported to Oars, we had access to pretty much the names of the medications that were prescribed, the quantities that were prescribed, but it's comparing apples to oranges. How do you compare a cannabis prescription to an opioid prescription? So we just had to keep looking at what question are we really trying to ask, and the question, in our mind was, well, what has cannabis done to the rate of opioid prescribing? So as we all know, over the past few years, there's been a big push in the state to reduce the doses of opioids that were prescribed, reduce those opioid doses. So coming into this, we knew that there was going to be a downward trajectory. When we began pooling the data, what we were seeing was there was a decrease in opioid prescribing from 2016 through 2019, and then it sort of leveled off. And right when it started hitting that level period, cannabis was introduced. So now what we're trying to see is, since cannabis has been introduced, is the rate of opioid prescribing going down at a quicker rate than it was, previous to when the cannabis program was started in Ohio. And that's where we are with the research. And we're hopeful that what we're seeing is significant. We are, working with Dr. Krish to identify all different kinds of external factors that, could have also influenced it. We've already alluded to, there's been pushes from the DEA, the State Medical Board, the Ohio State Board of Pharmacy to, make sure that pharmacists and prescribers are checking Oars on a regular basis to prevent patients from doctor shopping or pharmacy shopping. So all of those measures have resulted in a decrease in the number of opioid prescriptions in Ohio. What we think we are seeing and what we hope that we're able to show is, since the cannabis program has started in Ohio in 2019, that rate of opioid prescribing has gone down at a little steeper of a rate. Joe, love to hear your thoughts on what we're doing.
Well, I'm just amazed at your ability to find the right people to do these things. I mean, it's one thing to have the idea to pull all this data and be able to research it and analyze it. But boy, once we got with Dr. Krish and learned what was going to be what we needed to have done with these data sets, it was way over my head. I mean, you probably handled a little better than I did, but it's amazing. It was just, I mean, I don't know how many different Excel spreadsheets, and it would just take years to figure it out, and she knows how to do it. And I'm just loving seeing the potential of what the data can show us. I mean, we're not there yet, but like you said, we're seeing some interesting trends with when the cannabis program started, and we even see that trend not be, it helps when we find out, okay, how often patients are being prescribed gabapentin, or when certain landmark times happened with physicians being told they needed to reduce prescribing of opiates. But it really looks like cannabis is having a positive influence on patients' opiate and benzodiazepine use.
When are we going to see when are the results going to be published?
I'll let you take that one, AJ.
Or should I say, when do we hope to see the results being published?
Not soon enough, right? No, I think at this point we are, we're just looking over the data with Dr. Krish, and again, working really hard to identify any other potential cause that could have influenced the data to make certain that what we're seeing is related to cannabis. So it's like Joe said, it's one thing to get the data sets, and then it was another thing to sort of pour through them and learn how to extract the data that we actually needed, cut out all the white noise, and now completely different animal, and trying to make sure that what we're seeing is can be attributed to cannabis and not any external factors. So certainly gained a real appreciation for just for researchers and what they do on a daily basis. It's been pretty phenomenal.
Yeah.
So we're hoping we'll have something before the end of this year. As far as publication time, I certainly hope some folks out there will find what we're doing publishable. I think we have something.
I was gonna say, I can't imagine that they wouldn't.
So we hope.
So is Ohio seeing a reduction in opiates and benzodiazepines with the introduction to cannabis? Can you guys say either way whether you're seeing anything like that?
Yeah, we have to just answer that anecdotally. I mean, AJ and I see it every day with patients just telling us their stories about, I had to get off those medications. They were killing me, and they did. And I've seen it with my own eyes. People with MEDs in the 80s and 90s, hundreds, and now it's zero. Mm-hmm. So it's really heartwarming, but we all know, you got to actually have an actual valid study to show that, rather than just people telling us that.
Yeah, and that nice way to bring it back full circle, Joe, because it all started with what we were hearing and seeing from patients coming in and telling us that, oh, my doc's reducing my opioid dose. Oh, I'm off my opioids. And it's one thing to have a patient anecdotally tell us, but that's been the criticism of cannabis as a medicine the entire time in the United States, is, well, show me a study. And we can always point to anecdotal evidence or what we're hearing. So we're hoping this gives us something a little bit more objective to say, we've anecdotally heard it from patients, and this is what statewide we're seeing. We can't, at this point, we can't show a one-to-one study of patient X started cannabis on this date, and 6 months later their MED was this, and follow individual patients. But statewide, we are seeing a decrease in opioid prescriptions. The question that we're trying to tease out and answer is that decrease large enough of a difference in the rate from before that we can say that it could be linked to cannabis? And that's what we're racking our brains right now.
Excellent. I guess do you want to add to that, or on that note, are we done?